Let's dive right into this explainer. Look, if you're working anywhere near healthcare billing, coding, or documentation, you already know that evaluation and management, or EM codes, well, they're literally the lifeblood of practice revenue. But as you've probably felt, the rulebook recently got completely rewritten. Today, we're decoding those massive shifts to keep your practice not just financially optimized, but strictly compliant with the latest guidelines. We're going to make these complicated rules super clear and totally actionable. Let's get into it. We have a packed agenda today. We're covering EM fundamentals, the 2023 guideline evolution, facility and ED coding, how to dodge common documentation errors, mastering key EM modifiers, and finally, the bottom line. Section 1. EM fundamentals, the building blocks of patient care. Okay, so the absolute most crucial thing to remember here is that E&M codes exist to capture your brain power, the clinical judgment, the active management you're providing to the patient. It's really not about the physical procedures or surgeries. It's all about the cognitive work, evaluating a patient's health condition, making those tough clinical decisions, and managing their ongoing treatment. It's the thinking, not just the doing. And getting this right? Absolutely crucial. Accurate coding isn't just about, getting paid fairly for your time. It is a massive compliance issue. Messing this up risks heavy federal penalties. Actually, knowingly submitting false claims, that is straight up considered Medicare fraud. And misusing codes, like upcoding to a higher level or unbundling, that falls under Medicare abuse. Solid documentation is basically your shield against all of these risks. Section 2. The 2023 Guideline Evolution. Out with the old. Remember the old rules? They required that incredibly strict, tedious bullet counting across history, exam, and medical decision-making. It led to so much note bloat. Well, good news, we are officially done with that era. Under the new rules for office and outpatient services, you're selecting your EM level based on just one of two things, either your medical decision-making or your total time on the exact date of the encounter. Period. Now, if you choose to code based on medical decision-making, or MDM, your level depends entirely on where three specific elements intersect. First up, the number and complexity of the problems you're actually addressing. Second, the amount and complexity of the data you have to review. Think labs, old records, things like that. And third, the risk of complications or morbidity tied to your patient management. You always have to crosswalk your clinical documentation with this exact MDM matrix to nail down the correct level. All right, let's put this into practice with a quick hands-on exercise. Imagine a physician documents 72 minutes total for an established patient on the day of the encounter. This includes 50 minutes of face-to-face counseling for diabetes and hypertension, plus 22 minutes of chart review and documentation. So how would you code this exact time-based encounter? Think about it for a second. Got your answer? Okay, here it is. You'd build a maximum level established patient code, 99215, because that covers the 40 to 54-minute threshold. Then, since you have 72 total minutes, you slap on the prolonged service add-on code, 99417, for that extra 15-minute block of time. Remember, total time includes both face-to-face and non-face-to-face activities on the exact same day. So, both that counseling and the chart review count perfectly here. Section 3, Facility and ED coding. Different settings, different rules. Now, the emergency department setting is its own beast. Down in the ED, there is absolutely no distinction made between new and established patients. Everyone's treated exactly the same for coding purposes. Plus, you can never, ever use time to select your E&M level in the ED. It is strictly based on medical decision-making. And hey, if you're billing for critical care, your documentation has got to explicitly support that the patient's condition was life-threatening. No shortcuts there. Tricky same-day scenarios require really careful navigation. For instance, if a patient is seen in the ED and then admitted by that very same physician, you do not bill both. The ED visit basically gets rolled right into the initial hospital care code by the admitting physician. Understanding these specific workflows is an absolute must if you want to avoid those frustrating duplicate billing denials. Section 4. Avoiding common documentation errors. Okay, entering the danger zone here. You've got to avoid EHR cloning, that infamous copy-paste function at all costs. Every single encounter note must be completely individualized to support the actual intensity of that day's service. Another massive mistake, counting clinical staff or nurse time when you're billing a time-based provider code. You can only count the provider's time, guys. Oh, and missing a chief complaint? That can literally invalidate your entire EM code. Your documentation always has to tell the true, specific story of that patient on that specific day. Section 5. Mastering Key EM Modifiers, the Toolkit. When multiple distinct things happen during a single visit, you need the right modifiers. Let's focus heavily on modifier 25. You use this bad boy to prove your EM visit was entirely separate and significant from a minor procedure done on the very same day. We also have modifier 59 for distinct procedural services, 52 for when a service is partially reduced at the provider's discretion, and 95, which is an absolute must for indicating a real-time audio-video telehealth encounter. Time to test your knowledge again with a real-world clinic scenario. Let's say a patient comes in for a routine hypertension follow-up, but during the visit, they also have a wart removed, which is a minor procedure, code 11055. How exactly do you correctly code this so that both the medical management and the procedure are recognized and paid? Nailed it? You bill the EM code, let's assume it was a 99213, and append modifier 25 to it. Then you also bill the 11055 for the wart removal. By slapping modifier 25 onto your EM code, you're successfully telling the payer, hey, evaluating the hypertension was a completely distinct and separate workload from actually removing the wart. But a quick warning here, payers are watching modifier usage incredibly closely right now. The absolute #1 reason your claims might get denied? The documentation just doesn't justify a quote-unquote separately identifiable service. If your note doesn't draw a crystal clear line between the work done for the E&M and the work done for the procedure, that modifier 25 is getting denied and audited for sure. You have to paint the whole picture. Section 6, the bottom line, medical necessity. And it all comes back to this one guiding principle, medical necessity. No matter how much time you spent or how beautifully complex your medical decision-making matrix looks on paper, if the service wasn't medically necessary for the patient's condition, it is simply not reimbursable. So I want you to look at your most recent charts. Does your documentation truly tell the story of medical necessity? Or are you just taking boxes? And on that note, don't forget to like, share, and subscribe to Decode Healthcare with Harshal.